Our presentation is on multiple sclerosis, analyzed from a physiological perspective. Multiple sclerosis is classified as an inflammatory disease. An inflammatory response occurs when the immune system senses a foreign presence within the body and acts to fend it off. In the case of multiple sclerosis, the helper T cells in the immune system begin to view myelin as a foreign body. The ensuing response by the immune system attacks the myelin sheath of the neurons within the body. The body can slightly recover from these attacks through neuroplasticity and remyelination of the affected neurons. Remyelinations replace some of the myelin coating on the axons, but it never fully heals. Over time, fewer and fewer remyelinations are successful, leading to the formation of scleroses throughout the nervous system, typically presenting as plaques and lesions. Myelin is largely composed of lipids and is present in both the central nervous system and peripheral nervous system. In the central nervous system, it is produced by oligodendrocytes, and in the peripheral nervous system by Schwann cells. Myelin coats the axon in a beaded fashion with gaps in the myelin known as nodes of Ranvier. The myelin acts as a dielectric and forces the signal moving along the axon to jump from node to node. When myelin degrades, the signal transduction is greatly limited or even completely stopped. In 1996, the National Multiple Sclerosis Society set out specific criteria for the different types of MS. Benign MS is multiple sclerosis in which the patient will remain fully functional in all neurological systems 15 years after the initial onset of the disease. Malignant MS is used to refer to any multiple sclerosis in which the disease follows a very rapid progressive course. It results in significant disability or death in a relatively short time after initial onset of the disease.
There are four general distinct patterns of progression for MS patients, the first of which is relapsing remitting, which will be our focus of discussion. For most patients, it is the initial onset of the disease, and they experience random attacks or exacerbations that generally last for a minimum of 24 hours. In between the attacks, there are periods of recovery, which can be explained by neuroplasticity and remyelination. A second pattern of progression is the primary progressive form of MS. In this case, the initial onset of MS immediately progresses in a deteriorating manner that can have a changing rate, but in which there are generally no attacks. The next form, the secondary progressive, is common in that it generally occurs in people who are initially diagnosed with relapsing remitting. There are generally no attacks, but there is a more continuous deterioration. The final is the progressive relapsing, and it is the rarest of the four patterns. From the onset, the disease worsens similarly to primary progressive, but the pattern may still include defined episodes of attack in which the condition continues to worsen further. MS patients present a large variety of symptoms, which is part of the difficulty in its diagnosis. Some of the more prominent symptoms are discussed here. One group of these symptoms involves muscle weakness, problems with coordination, and problems with balance. These symptoms can involve damage essentially anywhere along the motor tract and sensory tract of the central nervous system, and particularly in the cerebellum. The cerebellum is located on the underside of the brain and is a primary center for coordinating motor control and regulating various sensory inputs. One symptom, ataxia, is the loss of muscle coordination. This directly involves the cerebellum, as it is the site of coordinating sensory information and information about muscle movements. Performing finer movement tasks can be difficult because the cerebellum is unable to synthesize these movements. Additionally, the cerebellum receives input from the vestibular senses, which controls the balance of the body, which can be disturbed in MS. Numbness is also a common experience and can be caused by lesioning anywhere along the spinal cord. Finally, in terms of the spasticity and uncoordination that MS patients experience, it's important to consider the relationship of the cerebellum and the ventrolateral nucleus of the thalamus. The ventrolateral nucleus receives input from the cerebellum and sends it off to the primary motor cortex, which then governs muscle contraction and movement. Demyelination can affect this pathway by causing an interruption in these signals and miscommunication of the signals, causing muscle spasticity. Various visual impairments are common in the experience of MS patients. An example is diplopia, which is the experience of having double vision. This can result from improper coordination of the extraocular muscles, which can be affected by disturbance to motor neurons. The inability to coordinate eye movements can lead to double vision, again highlighting the importance of the cerebellum. Additionally, nygmasia, which is the uncontrollable movement of the eyes, can be affected by damage to the cerebellum in relation to its regulation of balance. Optic neuritis is a major symptom and is caused by inflammation of the optic nerve, which coordinates between the retina and the primary visual pathway, leading to the primary visual cortex along the calcaneum fissure. This can lead to possible vision loss in one or both eyes. In an interesting article, Vlugels et al. Examined the localized damage to particular areas of the visual pathway. The magnocellular and parvocellular layers are two of the layers that compose the visual pathway through the lateral geniculate nucleus to the striate cortex. The magnocellular layer is involved in the processing of form, movement, and spatial information, while the parvocellular processes finer details, including color. These processing paths lead to the eventual divergence, which constitute the dorsal and ventral tracts of visual processing. The findings discovered that discrete damages do occur just as often as damage to both the parvocellular and magnocellular pathways, and this is helpful in diagnosing specific localizations of visual damage caused by MS.
A common symptom among MS patients is the onset of pain that can be either acute or chronic. Some common acute pains experienced are trigeminal neuralgia and Lermite sign. Trigeminal neuralgia presents as a stabbing pain in the face, and it is the result of a demyelination of the trigeminal nerve, one of the main cranial nerves. Lermite sign is an electric shock-like feeling that will run down the head and spine. It is believed to be caused by scleroses in the dorsal column of the cervical vertebrae or in the caudal media. Diastasis refers to general bouts of pain, usually experienced as a burning or aching sensation. It is usually brought on by a sclerosis within the spinal cord, and it can present as either acute or chronic pain. Another very common chronic symptom of MS patients is pain of spasticity. These painful spasms can be the result of damage to either motor or sensory neurons in the brain. The damage will cause the brain to fail in properly inhibiting reflexive signals. As mentioned earlier, a common area of damage leading to this pain is within the cerebellum. Another common area of deficit in MS patients is in cognition. Some common types of symptoms seen in these patients is loss of short-term memory, decreased attention span, decreased ability to process information, an inability to perform executive functions, a loss of verbal fluency, and an impaired visual perception. These symptoms can be the result of neuron damage in a number of different areas in the brain. Some other functions that will usually remain intact in MS patients are general intellect, long-term memory, conversational skills, and reading comprehension.
There is no cure for MS. However, there are different treatments available to make the disease more manageable. Thompson, in the Journal of Neurology, recommends these medications for each symptom. Certain medications can be prescribed to treat each symptom specifically. While fatigue cannot be satisfactorily treated, small trials report some benefit from amantadine. There is some evidence that patients with visual dysfunction may find relief with botulinum toxic injections. It works by blocking calcium-mediated acetylcholine release on the presynaptic terminal. To help ease the pain, muscle relaxants, notably baclofen, may be used. Baclofen is thought to work by suppressing excitatory transmission release by acting presynaptically. Steroidal anti-inflammatory agents may also be effective. The symptom that is most responsive to treatment is spasticity. Tinzanidine and baclofen are muscle relaxants that may improve muscle spasticity, relieving the painful and sometimes uncontrollable muscle stiffness or spasms. Tinzanidine acts to reduce excitatory transmission in the spinal cord. Botulinum toxin type A is also effective in treating spasticity. Stretching, in conjunction with these medications, is a key component to maintaining a full range of motion. Physical therapy is also used to make daily activities easier. A speech therapist can be helpful in dealing with a variety of communication problems that may accompany MS. Certain breathing pattern techniques that a speech therapist can recommend may be very effective. To properly determine the exact problem with swallowing, an expert assessment by a speech therapist is administered. This may include radiological investigation, specifically video fluoroscopy or endoscopy. Managing this symptom includes educating the patient, changing diet, and teaching positioning strategies to make swallowing easier. Thermal stimulation is also effective. It involves using ice to delay triggering of the swallow reflex. To reduce pain not relieved by medications, physiotherapy, along with local treatments such as heating pads and transcutaneous electrical nerve stimulation, are used. Cognitive dysfunction is treated on a case-by-case basis. Together, doctor and patient work out a comprehensive plan to lessen or overcome these cognitive deficits, and in some cases, cognitive rehabilitation is necessary. Corticosteroids have immunosuppressive and anti-inflammatory properties. They are thought to work by decreasing lymphocyte response to antigens, which can decrease inflammation. They may also reduce the level of myelin basic protein in the cerebrospinal fluid, which plays a role in reducing demyelination. Corticosteroids are used to reduce the duration of a relapse, but do not prevent the subsequent permanent deficits. According to Compson and Coles, corticosteroids are not successful in reducing disability because they are administered too late. A trial in which 90 people with relapsing remitting MS either received steroids only during relapse or regular post-corticosteroids showed that while relapse rate was the same for both groups, the regular post group had significantly less disability. This shows that regular post-corticosteroids do not change the mechanisms that initiate relapses in MS, but they can reduce damage to the axons.
One way of treating relapsing remitting MS is through immunomodulatory agents, which act as disease-modifying treatments. Since there is no cure for this disease, immunomodulatory agents are merely used for treating the disease and limiting the effects of it. The treatments include interferon beta 1A, which is administered via injection and prescribed under the brand names Avonex and Rebif. There is interferon beta 1B, which is also administered through injection, having the brand names Bedaciron and Extavia. Vladimir acetate is another, administered by injection with the brand name Copaxone. And the last two are fingolimod, which is orally ingested, and lastly metoxantrone, which is administered through intravenous infusion. The benefits of these disease-modifying treatments provide much-needed relief to patients, but they are accompanied by side effects that can be fatal. The interferons beta 1A and beta 1B are biotechnologically manufactured proteins. They consist of the same amino acids as the interferon naturally found inside the human body. The benefits of interferons include a lower relapse rate, a lower amount of lesions, and they slow the progression of disabilities in patients. Despite these beneficial aspects, there are side effects to taking interferons, such as flu-like symptoms. And it should be mentioned that interferons do not provide all patients with relief, and over time, for those it does provide relief for, the body will produce neutralizing antibodies that will limit the medication's effectiveness. Vladimir acetate is a mixture of amino acids. It's a synthetic protein that simulates the myelin-basic protein. The drug is beneficial through protecting the myelin sheath from the T cells, which are damaging to it. The benefits include a lower relapse rate, reduced lesions on the brain, and the progression of disabilities in patients slows down. In a study published in Lancet Neural Journal in 2009, consisting of 2,447 patients, it was found that Vladimir acetate and interferons provide no difference in relapse rates, increased lesion size, or the amount of damage done to the brain. So neither treatment is better or worse. It just depends on which treatment the patient prefers based on how they react to the side effects. Natalizumab is a second line of defense treatment, since taking it can develop multifocal leukoencephalopathy in patients, which can be fatal. Natalizumab should only be used if interferons and Vladimir acetate are ineffective because of the risks associated with the medication. Another is fingolimod. Fingolimod adjusts lymphocyte migration, limiting the amount of lymph nodes produced. This drug also reduces disability progression and new brain lesions. The side effects, including tumor development, are why it should be used only if interferons and Vladimir acetate are ineffective. The final treatment is metoxantrone, which restrains the activity of T and B cells, the cells that are destructive to myelin sheath. Side effects include a low risk of acute leukemia, which is why it should be used only in rapidly progressing cases where other therapies are ineffective. This next slide is our references. consisting of the journals that were required. Thank you.